Sorry, but I'm French, so English is not probably my preferred language. So, first, we had the opportunity to welcome the team of General Electric in my hospital 4 months ago, before the Olympic Games. I think that you see the cycle. It was a very great moment for French people, and here is some people coming from General Electric, and Ala Woodson from Madison, I think. That's right. So this is a plane. We change. So where is my city? My city is just here. I think you know the city. There's a arena, les arènes, where we can fight with belt, if you want. And during summertime, there's a big concert, for example, for music, and we had the chance to hear some great autos last summer. So my hospital, very sorry, it's a digital hospital, no pen, no paper. No pen, no paper. Can work with and use all without paper. It's a very small city, but a very big hospital. I'm the chief of this department with more than 50 consultants, more than 15 residents. We perform more than 20,000 surgery every day, larger obstetric and other surgery for endoscopic cardiology, and also we have a large number of intensive care units beds, as you can observe, and we have operating rooms. We have 24 operating rooms and 8 non-surgery rooms for obstetric or radiology. So this is my anesthetic station. This is my operating room. Always a care station inside. Always this. All the rooms are worked with GE IZCS2 ventilator. All the rooms, okay. And this is a monitor, including entropy SPI. We have no pen, no paper for anesthetic file. All record on the screen, and all the data are translated to a cloud, for example, for the anesthetic screen, or for this today for General Electric application, for example. Okay? So this is my environment. So first question is why we have to change our practice? Okay, but why and how? So remember that every year we perform more than 300 million anesthesia over the world, and when you're looking at this map, the number of anesthesiologists and anesthesia is unevenly represented around the world. It's different in America, in Europe, and also in South Africa. But it's not very important. What is important for us is to reduce complications after surgery. This is the main point for all of us: reduce complications during and after surgery. Reduce initial complication, pain, urinary retention, nausea, vomiting, ALS, and probably complication due to respiratory adverse events, sepsis, thrombosis, wound infection. It's a lot of money, it's a lot of readmission, and it's a lot of morbidity and mortality. Probably between 2 and 3%. We perform an audit, a very important audit, using AWA this year, and this is the rate of complication in my institution for major surgery. So, question is today how to reduce mortality, morbidity, or to improve quality. So there are 3 ways, probably there are 3 ways. The first one is to use better care pathway using ERAS program, PROMS and PREMS, patients reported outcomes and experience. Okay. Second way, sorry, I'm not a surgeon, reduce and use better surgical procedure. Choose your surgeon, of course. And third, change of practice, of course. Evaluation of anesthesia with objectives and use monitor strategy to reduce inadequate monitoring to improve quality in your team. So probably we have to change our practice and to use feedback, because feedback drives progress. And you can observe on the slides a review published last year that clearly demonstrated the interest of the use of monitor and how we have to use it. And probably this is a new way for anesthesiologists to improve the quality. So this is what we show this morning. So feedback-driven progress, but how and why? Probably using this step. First, for all of your procedure, use a photo baseline, photography, then perform education, of course, and third, evaluate with probably with our or other applications. You can use paper reports, which is very complicated, or you can use automatic reports, as Professor Mullier said before. So I like to show you two experiences with our care station. First one, of course, pop ventilation, and secondly, what we can perform now for SPI entropy and hypotension. So first, start with our care station using pop ventilation. So we published 2 years ago a very interesting study with the use of AOA using this traditional and digital analytic intervention. And my primary endpoint for my team was please reduce complication, reduce intraoperative complications using pop ventilations. If I ask you, do you use pop ventilation? You will say, yes, I use it. But in practice, what's happened in practice? So that's what we perform. So just 2 slides. This is my friend Emmanuel Futier and Samir Jaber and Professor Mullier said to us, please use guidelines, for example. And I think in my hospital, we worked with these guidelines proposed by Emmanuel and Samir with preoperative pre-oxygenation using CPAP or PEP. Use a long protective mechanical ventilation, of course, and probably use a prophylactic post-operative non-invasive ventilation. We publish all this data in very important studies like in New England. And then I asked my team, please do it. Perform proposed ventilation. So for the first part of the study, we decided to demonstrate how many anesthesiologists use low tidal volume, use correct PEP and recruitment. We performed this study. This is similar like Las Vegas study published 5 years ago in a lot of countries. But the main problem with the study, as described by Professor Mullier, was it was a reporting, a very consuming time reporting, using, you see, paper, using pen, using app. And probably with our care station, it's performed automatically. And what is very important is you can perform it as soon as a new patient case is opened. It's very, very interesting. No human intervention. You can decide, oh, I want to perform an audit tomorrow. No problem with the system, of course. There is dashboard production. So we performed this study. So this is the timeline from our study. Started 5 years ago. This is a baseline. We recruit more than 2,000 patients. So we stop the record. We perform intervention and educations for our team. And then we perform monthly or 2 months or when we can perform audits for all of the anesthesiologists. But the time when we perform audits were unknown to anesthesiologists. It's very important. And then we start the study and perform a last evaluation after 1 year without any educations. So that's a result published. So this is the baseline. 7% of the patients of the anesthesiology had the triad, low ventilation, PEP, and recruitment. It was very low, but now the number is 22. Using these applications to perform educations and repetitive evaluations. So key points for this first study published was initial low protective ventilation adherence for my team and for your team also, effectiveness of multiple intervention, and it's very interesting to use this application to have more data and investable data. So it's not a new tool, but more than just a tool, it's a management aid. New management method based on repetitive audits with indisputable data and targets linked to complications. If you can link the dashboard to your patient baseline, your data center. It's audits that you can carry out at any time to drive team change. It's very interesting. So this was our first study. Secondly, we worked with Regis and Peter to use the new way of the care stations applications and to integrating entropy, SPI, and probably the level of hypotension during an intervention to be sure that entropy, SPI, and the map pressure stay within range that were probably defined by your team. So, because probably depth of anesthesia monitoring and nociception monitoring play crucial role in the anesthesia care and patients' outcomes, of course. I like this painting from Van Gogh, you know, this painting. So this is probably the sky, stars, entropy, SPI, blood pressure, but we have to connect in practice. You can just have a look on SPI and nociception, on blood pressure. You have to link, to connect all the data to manage your anesthesia. Of course, just looking or just focus on only one star doesn't mean sense. You have to link everything. It's difficult. So, problems on-premise in anesthesia remain complex, of course, and their objective uncertain and unvalidated. So best practice to share your anesthesia include probably level of hypnosis, sevoflurane or propofol, okay. But you have to monitor the brain, probably with BIS entropy, especially with propofol, of course. And perform action, change your MAC, for example, or the propofol target. You have a look to the blood pressure with, you know, this curve. This is low blood pressure that increase probably mortality, and conversely, high blood pressure probably increase mortality too, and the good pressure range between probably 60 and 80, I don't know. And then you have to work on new concept nociception and monitor probably SPI, none other target, and for have a new action, you can probably reduce your opioid in the intraoperative room, and you can use non-opioid agent, for example, ketamine and dexmedetomidine. And as Professor Mullier said, be sure that you use monitor with train of 4 your patient to be sure that at the end of the surgery, the complete reverse for this agent. So it's difficult, but you can do it. You can do it. So what we try to do in a prospective observational study in my institution is to link deep anesthesia monitoring nociception to all of the data of MAP, SPI, entropy using our care stations applications. So my primary endpoint for my team, I asked my team, please reduce complications after surgery using effective entropy SPI below the range, and perform educations for alternative and repetitive education staff. So we perform this study. We start on May, Regis, I think. May, we start at May. Yeah, May, sorry. To record the baseline. We perform the education, and now we are at step 3. I will show you. So, for example, why we choose this method and why we choose our care station. This is a case. This is your case. For example, in your institution, this is a man or woman as a number 2 with some complications before surgery. And this is radical cystectomy under general anesthesia using epidural thoracic analgesia. And patients will be monitored after surgery in intensive care unit. So let's have a look on the anesthesia file. it's difficult to know actually on this slide what the number and the duration of hypotension. It's difficult. And to be sure that the level of entropy during all the surgery is between the good range that you predefined. It's difficult. I can do it, but it's difficult. So using our dashboard configuration, this is very simple to have to have correct data and to measure the level of blood pressure, probably, or in this case, less than 65, with the correct duration of hypotension. So, how to do it in your institution, for example? So you have to do it step by step. First step, you have to evaluate the patients, and remember, you have to evaluate your team. So let's start with patients. You don't have to see all the patients because it's impossible. Probably you don't have to monitor patient for simple eye surgery with this system. It's crazy. But probably you have to collect data and you have to define your populations, probably for major surgery or intermediate surgery. For my study, we decided to use the definition of the American Heart Association, which will be more simple for publications. And surgery that will perform in hospital surgery with major or intermediate risk. So define your population. This is the first step. Second step, set monitor threshold in the app. It's very important. For pediatric surgery, MAP ranging differs as compared to adults. So go to the our configuration and use guidelines. For extubation, for the top, it's very simple, 90. But it's sometimes difficult to record the effective and the appropriate blood pressure for adult. For my study, we decided that the low range of hypertension was 60. But in some study, it's 65, some other is 70. You have to choose. This is your team. You choose with your team the level of hypertension and the duration that you want to record. Fourth, define your outcomes. Outcomes with hour, it's different. Outcomes coming from your database of patients. Entropy map coming from our dashboard. You have to we create a link between those both databases. It's possible. So for my study, mortality was impossible for primary endpoint. It's too much complicated. So we decided to look to morbidity. And after opioid sparing and values range, of course. Next step, you define the populations, you define the surgery, you have to assess your team knowledge. What do you know about entropy? What do you know about SPI? What is SPI? What are the ranges? So, for example, this is the example of my study we performed in June this year, a pretest questionnaire including a lot of anesthesiologists and consultants and residents and nurses in my institution. For example, this man. We perform audit using questionnaire linked to QR code, very simple. Start, you pass, and answer during the surgery. So results. Results for the baseline, we decided that all the questions range between 0 and 10. The median was 62. We use education staff and also sent published data to our team and perform a second evaluation. This is the education time, and you see that an increase in the number of points for my team. This is plus 10 points. This is an example of evaluations, and we sent to all the anesthesiologists of my team their results per anesthetist and for all of the team. Probably it's better to say for all of the team, you can observe an increase in your response. Then, Starts the second phase. So for baseline, we start the study in May. We recorded for major surgery more than 500 cases from May to August. The mortality for the first stage was 1.5, and we have a look to the use of entropy, the use of SPI. Very, very, very bad. Very bad. Very bad. Number of patients with use entropy or in the good range, predefined, very low, very low, very low results. We have the monitor, but we don't use it. Very low. Similar in another way, you can observe the data from April, so very, very bad. So we perform an education. This was the phase 2. And after education, we record a lot of cases, and now you see that's the percentage increase. So step 1 was baseline, step 2 was education, step 3 was a new evaluation, and you can make a cycle and continue this evaluation. So to summarize the results of the study using our dashboard, for example, for the management of your team, we decided to perform 2 studies. Study was on LPV ventilation. Study 2 was on morbidity, using our dashboard, using a baseline with a pretest with questionnaire, and including a large number of cases, with education for the step 2 and step 3. We perform evaluation, and we observe an increase in the correct response between the 2 steps. Now, for the patients, we know that we have included in the step 3 more than 300 cases, and probably we will finish end of November, I think, end of November, with more than 500 cases, and publications probably March to April, probably. So, to summarize, this is a monitor. Step 1, anesthesiology, use propofol. And just have a look on heart rate, on saturation, on blood pressure, probably because they doesn't know, they doesn't mean burst suppression, what is it? I don't know. So they don't look to this number. But after education, they look to this. The level of entropy, the level of SPI, to improve the quality of anesthesia. Probably at the end of the study, there will be no difference between morbidity and mortality. I don't know. But we try to change our practice, and I think that we success using our dashboard. For example, this is the date. This was last week, I think. Yes, this is my room number. This is room number 14. So here is 2 cases. The first one started at 8, the second at 12. In the first one, there was a percentage maintain time with loss of control 100%, very good. SPI good, no problem, no hypertension. Case 2, it's different. It's different. The difference between both cases, the team. We changed the team between the 2, and this is the first team and the second team with different value. Of course, this is not the same patient, but this is, I think, a very interesting case for the demonstration. 5 minutes? Okay, this is the end. So, lessons from our projects and lessons from change management perspective. Big Brother is watching you. This was the first question in my institution. Philippe, we have Big Brother now. So, lessons from my team and for me. This is more than an app. This is a team project, first. Second, this will improve quality of monitoring and the way you use it. It's very important. Now, you will improve the quality, you will increase the knowledge for all of your team, working towards goals, objectives, and you can perform very easily repetitive audits without human intervention at any time. It's very important. Negative feeling of being spied, of course. It's difficult to select patients, probably to select outcomes, and to perform a link between our dashboard and your database of patients. Because if you just have a look to our dashboard, and the complications, what's happened after? What's happened after surgery? You have to perform this link. It's difficult to do it. There is, of course, refractory to change and to the practice and to the management, and data have to be consolidated, of course, with new guidelines, of course. It's very important. So take-home message for me: tracks your data, reliable data drive your improvement, care station automatic, independent and reliable data, monitoring the implementation of low protective ventilations guideline, and monitoring educational program implementation, delivery an appropriate and safe level of anesthesia using this app. Thank you.